Good morning, dear friend, patient, and colleague. So today we are carrying on with the education in neuropelveology, and the topic from today will be sciatic pain. So once again, my name is Marc Possover. I'm a neuropelveologist and gynecologist. So let's start directly with the first slide. Sciatic pain, a very, very common pathology in the general population. And once again, if we want to understand what is sciatic pain, we have always to come back to anatomy. So first, from the anatomical point of view, the sciatic nerve is the largest nerve in the whole body. It starts from the lower back and go down to the foot. And this nerve is a somatic nerve with both function to bring information to the brain and to get information to the brain. So this nerve control red muscle, that means voluntary motor function. And sciatic pain refer normally to a burning pain, tingling, electrical shock, starting in the lower back or in the bottom and going down to the along the leg, the dorsal aspect, the posterior aspect of the leg, sometimes down to the feet. So the symptom, you have the sensory and the motoric. The sensory function, it's once again a sharp pain, a shooting pain, electrical shock, and mainly what we call allodynia, burning pain, usually with a quite high level on a scale from 0 to 10, more than 5, and usually 7, 8, or even more. So once again, starting in the lower back, going down to the buttock, and following the dorsal aspect of the leg, the hip, and down to the foot. For the root we call L5, the pain below the knee will come in front of the calf, and the pain L5 will be on the superior side of the foot, and the rest of the sciatic nerve on the dorsal side of the foot. And the sciatic nerve once again has a sensory function and the motor function. And the motor function is mainly the motion of the ankle, so what we call the dorsal and plantar flexion of the ankle, the muscle of the calf, and the muscle of the buttock. So if the patient develop some trouble, the patient will have motoric and walking disorder. So the prevalence and incidence are quite high. Prevalence, once again, is how many cases in a whole population. Incidence is how many new cases in a population. And you see that the prevalence is quite high. It's somewhere between 10 and 40% of the general population. It's not easy to say because some patient will develop a sciatic pain, will not directly go to the doctor, will take some painkillers, some medication, some massage, physiotherapy. It will get better and will not go to the doctor. And in such a situation, will not get the information of the sciatic nerve. So, of course, the sciatic nerve, there are some risk factors that may induce the development of sciatic pain or increase the pain in a sciatic pain. And of course, sedentarity lifestyle. If you're sitting a lot, if you're not doing sport activity, if you're not moving a lot, if you're a little bit too obese, and of course, if you have diabetes, because we know that sugar in blood will attack the nerve, not just the nerve in the eye or on the finger, what we call polyneuropathy, but diabetes is able to attack also big nerve like the sciatic nerve. And the overall global incidence in the general population on Earth is somewhere between 1 and 2% per year. So that means per year on the Earth, 1 to 2% of the people on the planet will develop a sciatic pain. So you're going to a GP, to a general practitioner, or a fortiori to an orthopedic, and you say, I have pain in my buttock, in my lower back, going down to my foot. It's a typical sciatic pain. So the etiology, the first thing everybody will think about, an orthopedic cause. Orthopedic cause, even if the sciatic nerve emerge in the pelvic cavity, not at the level of the back, but in the pelvic cavity, and leave the pelvic cavity through what we call the great sciatic foramen, enter the buttock below what we call the gluteal muscle, and then go down. So, an orthopedic cause, the number one, the favorite of all orthopedic is the discus hernia, herniated disc. And for sciatic nerve, the main diagnosis is discus hernia L5S1. But when we are talking from discus L5F1, we are not talking from nerve L5S1. There are two different things. For example, the sacral nerve root S1 emerges from the sacrum, where you will never find a discus. So you cannot have a discus hernia that induces an irritation of the sacral nerve root S1. If you have a sciatic pain due to an irritation of the root L5 or S1, it's within the spinal cord, but not outside the spinal cord because of discus hernia. And that is exactly what we call spinal stenosis, when the lower part of your spinal cord is entrapped because the canal, the bone canal formed by the vertebra is too small and entrap compress the nerve. You have spondylolisthesis, the piriformis muscle. The piriformis muscle is a pelvic muscle that divides the pelvis between inside and outside. And the roots, what we call the sacral nerve roots, which will build the sciatic nerve, are attached to the piriformis muscle. So if a patient presents on an over-dilation of this muscle is much too big because of special sport activity like horse riding, marathon riding, bicycle, all these things, dancing, classical dance, for example, is a typical risk factor for piriformis syndrome. The piriformis syndrome will compress on the nerve and will induce a sciatic pain. So for the piriformis muscle, always do an MRI. If you see on one side, the side where you feel the pain, that the piriformis muscle is too big, too enlarged, it's a simple treatment. Radiologists have on the CT scan to inject Botox in the muscle, then the Botox will become thinner, and then the pain will disappear. Of course, we have some degenerative disc disease, osteoporose, sacroiliac joint dysfunction, and trauma, pelvic trauma, with directly trauma of the nerve or because of secondary because of scar tissue. So now forget the orthopedic cause. And if you see in the literature, you will find only the orthopedic cause. But as a neuropelveologist, neuropelveology, we are dealing with the pathology of the pelvic nerve. And because the sciatic nerve is located deep in the pelvis, of course, pelvic pathology will be able to affect the sciatic nerve. And one of these pathology in women is the endometriosis. Endometriosis can leave the uterus and go outside the abdominal cavity and even reach the sciatic nerve. And there are two types of endometriosis. One is what we call the sacral plexus endometriosis. We will have a special education video on endometriosis of the sciatic nerve. But now I can explain that you can have an endometriosis of the root of the sciatic nerve. And this kind of endometriosis normally don't destroy the nerve and induce sciatic pain plus urinary issue like hypersensitivity plus genitoanal pain, vulvodynia, coccygodynia, and so on. And you have another one with the same name, endometriosis of the sciatic nerve, but which is a completely different issue. The endometriosis of sciatic nerve is a very, very aggressive, destructive disease These endometriosis can destroy the nerve. And here you see, for example, two laparoscopic pictures. On the left, a patient with a small spot from less than 1 millimeter on the sciatic nerve. You will never be able to see such kind of endometrium in CT scan on MRI. We, as a neuropelveologist, once again, as certified neuropelveologist ISO level 3, we are able to make the clinical diagnosis, or at least the suspicion of an endometriosis of the sciatic nerve, just by patient history and clinical examination. And it's very important because this kind of endometriosis will start until 1-2 years to destroy the nerve. And you see on the picture on the right, it was a patient who with a big endometriosis from the sciatic nerve, which already have destroyed 1/3 of the sciatic nerve. Very important to understand is that this kind of endometriosis, you cannot treat it with any hormonal treatment. And it makes no sense to remove the uterus. It will not help. For that, you need really a certified ISO level 3 neuropelveologist who is really trained in the laparoscopic neurosurgery of the sciatic nerve. It's not gynecology, definitively not, to go to the nerve and to resect this endometriosis out of the sciatic nerve. And you have the second very important information is to know that endometriosis, isolated endometriosis of the sciatic nerve exists. So it's not because in MRI you didn't see anything, and not because during the laparoscopy your gynecologist didn't find any endometriosis in the abdominal cavity, that you are not affected by an endometriosis of the sciatic nerve. And here you see, for 2-3 years, we got the prize of the European Society of Gynecology Endoscopy for the best paper of the year. And this paper focused on 267 patients affected by such a kind of endometriosis of sciatic nerve. And what we found out is that this kind of endometriosis will not need 10 years to develop and to destroy the sciatic nerve. That is really a short story. Endometriosis of sciatic nerve will destroy the nerve until 1 to maximum 3 years. So from the diagnostic point of view, when a patient is coming with a pain, a sciatic pain since 10 years, with a question, could be the cause of my pain an endometriosis? The answer is probably not. Because once a patient develops an endometriosis of the sciatic nerve, she will develop neurological disorder with what we call foot drop and Tredelenburg gait in 1-2 years. It will not take 10 years, even if you bombard the patient with hormonal treatment. It makes no sense to treat that with hormone once again. The second, that is much more rare, much more seldom, are tumor. And one of the tumors of the nerve, a benign tumor called schwannoma. And this tumor developed from the protective sheet around the nerve. And this sheet is called Schwann. And that's the reason why this tumor are called schwannoma. And this tumor grows within the nerve. That means even if this tumor grows very slowly, the patient will develop very, very early, very soon, neurological disorder, exactly like in infiltrating destructive endometriosis of the sciatic nerve. And this schwannoma must always be removed because it will destroy the nerve on one side. On the other side, schwannoma can become a cancer. And there is no way to find out if this schwannoma will become a cancer or not, and if yes, when. So you have to do the surgery. Neurosurgeons are trained to surgery to the nerve, but not in the pelvic nerve. Neurosurgeons are coming from outside, are coming from the buttock, but are not trained in endoscopic surgery, in laparoscopic surgery. And schwannoma of the pelvic nerve are within the pelvic cavity. On the other side, gynecologists are not trained in this kind of surgery as well. So for that, you definitively need a neuropelveologist certified ISO level 3, which with several years of experience on this topic. Then the third cause for sciatic pain, a neuropelveological cause for sciatic pain, and surgical damage. And if you think how many procedures, surgery performed every day over the world within the pelvic cavity, in men, in women, in kids, it's obvious that the prevalence and incidence of nerve damage, pelvic nerve damage due to surgery must be very high. But data, statistic data, are very, very difficult to gain. Now, when you have surgical damage, there are two types of surgical damage. What we call the primary surgical damage, that means you burn, you cut a nerve, the patient will wake up from the anesthesia. The day after, she will feel an incredible pain. And then you have the secondary lesion, is you do a surgery close to a nerve, maybe there is some inflammation, some hematoma, and this hematoma inflammation will build over time some scar tissue, and this scar tissue secondary will start to entrap the nerve. And this kind of surgical damage, the pain develop several months after the procedure. And then another cause, and the much more frequent cause, and no any gynecologist, orthopedist, neurosurgeon, neurologist are thinking about that, is what we call vascular entrapment. It's the compression of pelvic nerve, like the sciatic nerve, due to by enlarged or atypical vessels. And if you see on the picture below, here we have a sciatic nerve at the end of the procedure. When we start the procedure, you see that I try to increase, you see that a vessel was pressing the nerve. So, over the last 2 years, we made a retrospective study where we check for possible cause why our patient develop a vascular entrapment with compression of the sciatic nerve. And what we discover is that more or less 30 to 40% of the patient behind the vascular entrapment are suffering from an autoimmune disease. And the most frequent autoimmune disease correlated with a vascular entrapment is what we call an Ehlers-Danlos syndrome. And you can make easily the diagnosis if you're able to bring your thumb to here, or like this lady, you have an over-angulation here, then you have the diagnosis or the chance to have an hypermobility joint syndrome. And one form of this disease is what we call the Ehlers-Danlos syndrome. But maybe you have another autoimmune disease like lupus, like thyroiditis, Hashimoto, gluteal intolerance. And all these autoimmune disease are risk factor for anomaly of the pelvic vessel that may induce a vascular entrapment. And that is a knowledge we won over the last few years in neuropelveology. Now, when you have a sciatic pain due to a neuropelveology condition, then you can treat it because you have the cause. And how to treat it? That is, you use a laparoscopy. You cannot use Botox for that. You cannot block the nerve for 6 months, 9 months. So you use the laparoscopic. The laparoscopy enables the approach of all pelvic nerve, including the sciatic nerve, with a magnification effect. That means the sciatic nerve is on your screen and half meters. So you have a beautiful vision on the sciatic nerve to do something on the sciatic nerve. And the decompression means you release the nerve. So when you have a vein compressing the sciatic nerve, you will remove this vein. And for that, very important to never use clip, suture, or whatever. Because if you use a clip, the clip will be in touch to the sciatic nerve. And over time, you will develop the next sciatic pain, but not because of a vascular entrapment or endometriosis, but because of the clip. So, and now, suppose you have a sciatic pain due to a lesion of the sciatic nerve, then you have to bring no electricity on the nerve, and that is exactly what we call the Lion procedure. By laparoscopic approach, you can bring a stimulation lead electrode on the sciatic nerve within the pelvic cavity, and with this neuromodulation, we will block the transport of the pain information to the brain. That is the way high neuromodulation work. So I thank you very much for your attention. I hope that this lecture on sciatic pain is helpful for you, that if you're suffering from such a condition and nobody found what is the cause, think it could be a neuropelveologic condition. So thank you for your attention. Stay healthy and enjoy your life. See you the next time. Bye.